can welcome him.
Thank you. So I'm Pat. I've been at Mary Washington my whole career as a PA. I'm going on 9 years this month. I think this is probably the 4th or 5th year I've come here and given this lecture. So it's always good to see eager, bright faces. Usually it's later in the year I feel like worn down and hair's falling out.
You should have seen us.
How y'all doing so far? Is it
We're hanging. We're alive.
hanging
We're
there?
still here.
Pulse is palpable. So this is the first year I've given the lecture since I've hired a person who used to be sitting in your seat, and I found out during her interview that I can be a little bit boring. So if I am, just raise your hand and let me know, and I can try to spice it up a little bit. But she's doing very well as her new.
Yeah.
Oh yeah,
Killed it.
she was a student of ours too during the for her elective. So, how many people are going to be in the surgical realm after graduation? 3, 4, maybe. How about critical care, intensive care, ER, ortho, primary care? Okay. I'll try to cross the gap here. There's most of what I've always done is inpatient hospital, so this is the group of people I work with. We do emergency surgery, trauma, and surgical critical care. So we have a group of 6 advanced practitioners and 5 surgeons. You'll be meeting a few of them later in the year here. What I get tasked with talking to you about today is nutrition and wound care as it relates to the surgical patient. So it's something we do every day. Have to think about somebody's nutrition and how that relates to them getting better or getting out of the hospital and going home and healing from what they present to us with. So just a basic outline of what we're going to be talking about. This is by no means to be a biochemistry class here. I'm not going to try to bore you with all those extra details, but it's huge. It's a huge deal because up to half of our patients in the hospital are going to be malnourished, and that can cause worsening of their disease states that they present to you with. The consequences are poor wound healing, increased susceptibility to infection, rising decubitus ulcers, and the normal flora of your GI tracts can be significantly reduced. So there's an increased relationship with morbidity and mortality. So the stress of whatever it is, trauma, perforated colon, acute appendicitis even, that ramps your body up. It makes you hypermetabolic, and once you become hypermetabolic, you start using every resource that your body has in it to try to fight off whatever it is. So your protein and energy requirements go up, and your body will sacrifice everything to protect the brain and the heart. So those main macronutrients are going to be shunted and used by those bigger systems. Most healthy people, you and I in this room, we can go without eating a food and be okay as long as we have water or IV fluids for a week, 10 days even. So it's not a big deal for us, but somebody who comes in and is already cancer-ridden, has already had a perforation a week ago, they're already set up to be malnourished from the get-go. So we have to think about intervening sooner than later on those people. So the rate of malnutrition kind of depends again on what you present with. How malnourished are you hitting the door? How complex is the disease or the surgery that you're going to be going through? Acute appendicitis, same day, out the door. Perforated colon, you're there for a week to 2 weeks, and during that time there's potentially complications of the disease you presented with. So how long is that person going to be hypermetabolic, utilizing all those resources? So we intervene earlier on those with severe sepsis, major trauma, post-operative, prolonged operative, post-operative course. So this is just a general overview. We're just going to touch on this the basics of this quickly. the macronutrients, you're already learning about this in other courses, protein, carbohydrates, and lipids. But I want to just focus on how it relates specifically to GI surgery and other potential burns, critical care. So protein, it's not really used as energy fuel source necessarily, but it's a building block of everything. So hair, muscle, wounds, everything that you need to heal, immunoglobulins that you fight off infection with. For a normal person, you only need about 1 gram per kilogram. In critical care, that goes up by at least twofold, if not more. So it's usually digested in the stomach and duodenum. It goes into amino acids, and all of those amino acids are usually absorbed in the first part of the small intestine, the first 50% of the duodenum. But it can be done throughout the entire small bowel. So let's say somebody comes in with a twisting of their small bowel and we chunk out 30 centimeters. We're not going to worry about them absorbing protein because they have all the rest of the entire small bowel that can take those amino acids up. You can produce a deficiency if somebody has a tube in their nose and you're sucking out all of those gastric contents for days on end, and everything that's responsible for breaking down the protein into the amino acids is taken out. And then burns, that's probably the most hypermetabolic state you can imagine. So you just need so many protein molecules to heal burns that you can produce deficiency. Always think about your liver and renal patients because they already have a tendency to have problems getting rid of protein, so you don't want to overdo it with those folk. Carbohydrates, broken down into glucose. Glucose actually helps us to repair our wounds, but if you have too much and you're hyperglycemic for days on end, it can produce fatty liver, and it can actually impair your wound healing. It begins in the mouth. Later, pancreas helps. Again, most of the first part of the small bowel is going to help with the absorption, and deficiency is pretty rare, except in people who have celiac sprue or those flattening of the mucosal folds of the small intestine. Lastly, the lipids. This is what your body changes metabolism to in a fasting state. So now the big fad is ketogenic diets. That's what people are trying to, change their metabolism into producing ketones so that they can, try to help lose weight. But most of the ketones that we use are going to be used by our brain and our heart for metabolism. That, again, those are the organ systems that our body will sacrifice everything else. So usually, again, the upper part of the intestinal tract, the fat enters the system, the gallbladder contracts, it gets into these little soapy molecules. The soapy molecules get brought across the mucosal membrane into the system. But it's the last part of the small intestine, the terminal ileum, that all those bile salts that bring those fat molecules into the soapy molecules, the bile is essential for that process, and you have to reabsorb and recirculate the bile to digest the fat. So if the last part of the small intestine, the terminal ileum, if you resect that, now you're going to start dumping all of your bile salts, and you can have diarrhea, and you may produce a long-term deficit of fat molecules, lipid molecules. Just one note here that if somebody's on TPN, that's IV nutrition we'll talk about in a little bit, most of that is going to be glucose and protein, but you have to give them fat at some point during the week, up to 3%, because there's certain fats that are essential. Your body can't make them, so you have to give them fats in order to prevent some of the deficiencies related to specifically linoleic acid, which relates to wound healing. These you can read on your own. Just don't forget there are a whole bunch of micronutrients if you're constructing somebody's dietary intake, whether it's outpatient, inpatient, at home. You have to provide them with micronutrients. So back to our stress metabolism. It's always a balance between breaking down, building up. So you're going to be breaking down all of those major molecules when you're in a stressed out state. And that is a rapid rate of protein loss. Your body is ramped up. It's trying to fight off to save its life. It's going to increase the basal metabolic rate and just start crashing all those stores. And most of those patients, we're not letting them eat because they're going to the OR sometimes 2, 3, 4 times in a week. So then once they've kind of gotten out of Dodge and their body is starting to get on the mend again, their sepsis is under control, now they're starting to shift out of the breaking down phase and they have to start building up again. So the early part of the anabolic phase is, again, a little bit of a rapid process. Usually once a disease process kind of get a hold of it, it can reverse its course quickly. That early phase can last a few weeks to a few months, depending on how severely malnourished they were when that anabolic phase started. And then late anabolism is just, it's a slower gain, and that's when your body's working on beefing up the fat stores. So that's kind of the point of later anabolism. So what are we going to do? Whether it's inpatient or outpatient, what are some things that we need to know about the patients that are coming to us for help? But always taking a good history and doing a good physical is key to whatever, it doesn't matter what department you're going to be in, but you want to know about their chronic disease states. Do they have liver disease? Do they have diabetes? Do they have kidney failure? Because they'll be either malnourished. Diabetes puts somebody into a hypermetabolic state. They're always in a stressed out metabolism, so that even though they may be morbidly obese related to their diabetes, they're still relatively malnourished. Weight loss, weight gain, whether it was intentional or unintentional, changes in dietary habits, any infection currently or in the last few months that could have taken down their stores of protein, especially. Any hospitalizations, they could already come to us with bad sacral D cubes or MRSA in their bloodstream and don't know just because they were hospitalized. Any surgeries, especially bowel resections, medications or supplements that could impact how they absorb nutrients, nausea, vomiting, whether they can't swallow or it hurts to swallow. Somebody with a stroke, you're not going to be able to start force feeding them big chunks of steak and expect them to swallow it safely. So it's really important to think how you're going to get that patient some nutrition. And then a physical exam. Vitals always come first because they're vital. So what is somebody's height and weight? BMI is it has its downfalls, but it's a good estimate of somebody's nutritional status. Let's hear somebody else talk for a little while. What are some things that you already can point out about this patient that scares you when you're thinking about cutting him open? How is he underweight? Okay, good. So he has very sunken cheekbones.
His lips are dry.
Yes, very good. Very dry, cracked lips. There's another few things that might jump out at you.
Is he jaundiced?
He is jaundiced. Yep. So he probably has some underlying liver disorder that we need to think about. What other fat pad is important here? Above the jawbone, the temporal fat pad. That's a huge area that somebody comes to with that sunken temporal fat pad. They're significantly underweight. And the last thing is the hair. His hair is not necessarily, well, it's not groomed, but it looks a little bit retracted and and hair loss, patchy hair loss. So just in general, somebody's fat. What's an easy way if you're pre-oping a patient for surgery? They come to your office. How can you test their fat and how it might relate to national standards? Exercise physiologists in here? Kinesiology? Calipers, you all know the pincher caliper things. Take it on their tricep. There's a standardized age-based population for females and males. You can just pinch their tricep area and compare them to national average. HENT, we already talked about the temporal wasting, the hair loss, the gums. There's something, I'm not sure if you guys talked about in history and physical. There's a picture of angular chelosis, a little crusting at the corner of your lips. It's usually a vitamin D or C deficiency. And then glossitis is that shiny tongue that's kind of lost the normal appearance, usually a vitamin B deficiency. So then cardiovascular, patients who have severe anemia from B12 malnutrition or other problems, they could be in a high output state. They could be tachycardic at baseline. Their heart PMI might be displaced. They could have distended neck veins or edema in their legs. Those are things you have to think about when constructing nutritional recommendations. Look at their abdomen. They have a fistula from the small bowel. Do they have a gastric tube in place that's draining bile every day? Do they have an ostomy? Is it a colostomy with colon, or is it an ileostomy from the small bowel? So that's going to be a huge difference of whether it's colon or small bowel from just a pure volume standpoint. Ileostomy will dump 2 or 3 liters a day because you're not retaining water from the large intestine. That's the job, the large intestine. Extremities we kind of talked about. Strength, what in your office setting, how can you test strength and compare it to national average? You're going to have them get on the ground and do push-ups for you, or put a chin bar in, and resistance, what kind? How do you calculate that?
5 out of 5.
Your 5 might be different than his 5. So again, kinesiology, there's a hand grip strength manometer that it will give you either a digital or some kind of score that you can compare to male, female, age based standards. Neurologic, do they have peripheral neuropathy from severe diabetes? Do they have tetany from calcium deficiencies? Are they irritable or confused? Maybe they have underlying sepsis that we're not seeing. And then just looking at their skin. So again, I'm not going to go over this, but this is just kind of for your reference of how important those micronutrients are and all the different physical exam finding. You don't even have to touch somebody, and you can walk in a room and see more than half of this list. So these are just different, now that we've moved on to kind of diagnostic studies and data and how we can test for somebody's deficiencies. As far as protein goes, that's probably the one that we test most frequently in surgery. You want to know what their baseline is and over time if you're improving it. So in albumin, you can check serum albumin. If it's less than 2.2, they're hosed. It's very significant. That person will have a very poor outcome just because of nutrition. Transferrin, I've never checked. Prealbumin is, I will state before any of this, none of these are actually hugely beneficial in somebody with severe shock or sepsis. They're all very dependent on somebody's fluid status. So if you've given them 10 liters of saline overnight, and their albumin's 2.2, that doesn't really tell me much. But if they came in a week after their sepsis and they're 2.2, that's very significant. So prealbumin, it's helpful because it's the fastest one to change. I can check it every 3 days and tell you whether I'm helping you or not. If the tube feeds need to be adjusted or your TPM needs to be increased. So that's kind of the helpful part about prealbumin. And then when we start talking about how we're going to intervene, just always remember the mouth and eating is the most ideal route. If you can use the GI tract, you should use it with usually a tube supplement. And then that very last resort, last resort is TPN, or parenteral nutrition, which is through the IV. So normally, just if you can, you just put them on a regular diet. They eat what they want to eat. Recommend things with good protein in it. But you can also supplement with shakes or ice creams or bars or whatever your institution has. There's tons of products out there, and you can either give it through their mouth or you can put it in a tube and they can get it that way. So enteral just means using the GI tract, and there's a variety of ways we can do that. Usually through a feeding tube, and of course it's much more ideal to use the GI tract than IV route, because putting food in the GI tract helps to maintain the normal bacteria in the GI tract, and it doesn't allow overgrowth of other nasty bacteria. The mucosal integrity is maintained. All these things help to our body, the GI tract, fight off infections that could come through the GI system. So there's less bacterial translocation, there's less endotoxin release from bacteria into the bloodstream. You have reduced rates of C. diff. So these are just some basic indications for enteral nutrition when somebody can't swallow. So somebody in a coma, somebody with a severe stroke, dysphagia, altered mental status, they're not going to swallow safely because they're going to be at risk for aspiration. If their esophagus doesn't contract normally and push that food south, again, it's going to come up north and they're going to aspirate it. If the stomach body itself doesn't contract to get rid of the food, it's going to come up north in the lungs. So either a gastric outlet obstruction, gastroparesis from severe diabetes, and then just generalized supplementation. Somebody who's been in severe shock for 7 days, a regular diet might not be good enough to get them over the hump to start healing these nasty wounds. And then pancreatitis, I kind of relate that to a burn because it's internal burn. Nasty pancreatitis is a huge protein soaking disease process. You got to get that person nutrition to get over their pancreatitis. So these are different routes. Have you guys seen feeding tubes, NG tubes? Does anyone put one in? It's not the easiest thing, nicest thing to do. Patients usually hate it, but it'll either make their nausea and vomiting better or it'll help get them nutrition. So it's a very important thing to learn how to do when your rotations next year. So usually a feeding tube, it's either going to go through the nose down into the stomach called an NG tube, or you can have a PEG tube or duodenostomy tube. PEG tube usually goes through the skin into the stomach, and a J tube goes through the skin into the jejunum. I'll kind of talk to you about that here in a second. You can put if somebody's on a ventilator, you can put an OG tube. It's easier to do, less cumbersome. This one up here with the blue, at the top here with the blue port, it's called a sumping tube. There's 2 lumens that allows you to suction out fluid from the inside. So it's very good for decompressing the stomach, somebody with small bowel obstruction or whatever have you. You can use it to feed, but it's not the most ideal because you can erode the sinuses or the nasal mucosa and cause pressure ulcers on the inside or bleeding. So usually feeding tubes, it's the same route, but they're skinnier and softer. So they don't cause as much of that irritation in the nasal passages. You can leave them for much longer. They usually have and they're usually a single lumen, so you can't drain the stomach. So if you're worried that you're going to have to drain the stomach at some point, you shouldn't have a small skinny tube. You want one of those big fat tubes for drainage. Anytime you put a tube, especially if you're going to feed the patient, not only do you auscultate to make sure it's in the stomach, but you want to check an x-ray to make sure you haven't put it down the lungs. If you start feeding the lungs, probably are going to get a lawsuit. So this is a gastric tube or G tube. Typically, we'll put them in the ICU. Somebody who's already on the ventilator for a while. Put a gastroscope like a GI doctor does, EGD, go down into the stomach, fill it full of air, and then under direct visualization, after the stomach is full of air, you can stick a needle from the outside, watch the needle come into the stomach, thread a wire, and then once the wire's there, you have free access to the instrument and put a tube as you can. So it's pretty simple procedure. It gets the things out of the nose. It can be a long-term access. People can go home, easily take care of them. You can do if somebody's had a lot of upper GI work or gastric bypass or some of these other more, Whipple procedure, and their anatomy is configured differently. Your last resort is always going in and doing a surgical G-tube. Obviously, that's a little bit more risky if you can avoid doing it. And then post-pyloric just means after the pylorus in the stomach, the strong muscle. It's getting a tube to feed the patient beyond that muscle, and you'd want to do that for somebody with gastric outlet obstruction, gastroparesis, head of the mass, pancreatic mass, something like that. Or a small bowel feeding tube goes through the nose down into the small intestine. This is just a diagram. You may come across a PA-J tube or a GJ tube. GJ just means there's two lumens to the tube. There's a gastric lumen and a small bowel lumen, a jejunostomy lumen. So usually you'll put somebody, if you're worried about, again, gastroparesis or inability to empty out the stomach body, you put a tube in there that drains the stomach, and then you can feed distal through the J tube. So it's a drainage tube plus a feeding tube in the same approach. This is a surgical J tube. A lot of times you'll do it in procedures that involve the esophagus. A surgeon that's working on the esophagus or does a Nissen, a very complex Nissen, or some upper GI reconfiguration surgery, they don't want to necessarily feed through the mouth or feed through the stomach for a while because you're worried about all the staple lines or suture lines, but obviously you need to get that patient nutrition. So you put a J tube at the same time, and a J tube just going through this, the small bowel moves all around. So you have to take part of the small bowel and suture it to the abdominal wall on the inside, and then stick a tube through it. And that's called a Witzel procedure. So that obviously is more of a advanced, more risky procedure. This is just contraindication why you wouldn't use the GI tract. If somebody has an obstruction or a severe ileus after surgery, you're not going to put more food down their GI tract because they're just going to vomit it. If somebody's having severe diarrhea already from whatever it is, C. diff or one of the other infectious diarrheas, the content of the tube feeding product is already so hyperosmolar that usually even in a normal GI tract it will cause diarrhea. So if you give it to somebody who's already having diarrhea, you're just going to make it much worse. And lastly, fistula, high output fistulas, because the tube feed will just come right through wherever that fistula is going. And then somebody on pressors in the ICU, those pressors are causing vasoconstriction of small intestine to perfuse all the other organs that are more important. So they're not going to be able to digest or metabolize the food that you're putting down into them. These are just different feeding products. The simplest version, you can take anything, put it in a blender, and put it down a tube and feed the patient. So anything that patients can go home, their family can cook whatever meal they're eating and throw it in the tube and eat it. But some families aren't okay with that, so there's a whole bunch of commercial products out there. They usually a tan bottle you'll see at the bedside through a pump. The pumps through a tube. And then these are just complications of tube feeding. Again, clogging the tubes, especially with skinnier tubes, that's much more of a chance of clogging if it's skinnier and longer. Aspiration, especially if they have GI tract dysmotility, tube feed's coming back up. Refeeding syndrome is pretty important to know, especially in your chronically malnourished patients. You'll see it most described in anorexic bulimic kind of literature, where somebody has been years on end with a severe mental disorder, and you want to get that patient good protein or nutrients, and you start refeeding them under guidance, they can go into a huge fluid shifts and go into either cardiac dysrhythmias from potassium changes. Usually you'll see phosphate, magnesium, and potassium all go into the toilet within the first usually the first 24 to 48 hours of restarting that food. And because of those fluid shifts and electrolyte shifts, they can have cardiac failure, cardiac dysrhythmia, respiratory failure, end up ventilated. But it happens in other populations too. Cancer patients who've had severe malnutrition. Yes?
I was just going to say, when they rescued people from concentration camps, the soldiers gave them food, and they had been so malnourished for so long that when they gave them the food, they died.
Oh, wow.
Yeah, it was a mix.
All right. There you go. A little historical fact. Thank you.
But it's just sad. They were trying to give them food, to be nice.
Yeah.
Yeah.
That's going in next year's lecture. Thank you. Yes.
Is there a way to prevent that, or you just have to watch it?
You have to be cognizant of it, and you have to watch it. And if you see potassium and phosphate going way down, you have to really ramp up your replacement of that, either IV or oral route. So usually, most of these patients are going to be at least day-to-day contacts, if not hospitalized patients. And then diarrhea we already talked about. Parenteral nutrition just means through an IV. Sometimes you can do it through a peripheral, but I've never seen that actually done. More than likely it's total parenteral nutrition, which is through a central line, either a PICC line in the arm or a central line in the neck or subclavian. The PPN, it's such a large volume of content that you can't get that person the nutrition they need without putting them into CHF or significant volume overload. So TPN, again, a central access, provides protein, carbohydrates, and lipids, and then you can add in whatever else you want because you already have good IV access. Most of the time, every institution you'll go to will have a pre-filled TPN order set. You just kind of have to check a box, and most people can get the generic off-the-shelf one. And then if you start changing or modifying things, adding potassium, phosphate, all the other nutrients, usually a dietitian is going to be involved, an inpatient nutritionist is going to be involved with that patient's care. So usually you'll start slow. That's the other way to help prevent refeeding, is starting slow. Don't try to get them to full caloric intake in the first day or first 2 days. And then you want it off as soon as possible because there's so many complications with TPN. as soon as they're eating adequately or their bowel obstruction's resolved, you're going to stop that TPN and get them off of it. So these are just the basic complications. Anytime you put a central line in somebody, you can pop their lung. You can give them bloodstream infection. You can cause a DVT at that site or PE if it travels. So there's a lot of just central line complications. Again, the refeeding syndrome can happen. And really, it's very difficult on the liver because of the digestion process. Somebody can go into severe liver failure or steatosis of the liver that can be either reversible or non-reversible depending on how long they're on the TPN. So just some basic final things. For somebody off the street, your basic person, you're not really going to be overly concerned. That person can probably last 7 to 10 days without significant replacement. But if that person comes to you and they're already malnourished or they're in such a severe hypermetabolic state, you're going to have to intervene sooner than later. So those are kind of the key points here. And then always use the oral route. It's preferential over the IV route. Kind of where I try to rush through this a little bit faster because I much more prefer wound care, and then I have some lecture or some case series after the wound care to kind of show you. So if anyone have any questions about nutrition? Yes?
You said you auscultate after putting an NG tube. What are you listening for?
Usually you'll put your stethoscope on the stomach itself and you put an air bolus down the tip of the tube on the outside, and you can hear the air bubble on the inside of the stomach. If you don't hear it, it can mean a few different things. One, it's in the lung. You kind of already know that because the person's gagging or feels like they're choking, or it's just too high, like it could be up in the esophagus, hasn't made it all the way down to the stomach body yet. So you might just have to actually advance it further. Any other questions? Do y'all want to move on, or do you want a quick break? Okay.
I'll take it.
I may just still go. Oh, maybe it paused. No, it's still recording. Well, it's fine. Yeah, it's not. Do that again. Something about it being a mirror screen. I'm not usually in this classroom. And it happened last week, and the guy came and maybe I'll get it and I'll look at it. I'll just let it run. It's fine. I'll have to record.
You can edit it later, maybe.
What?
You can edit it later, maybe.
Yeah, exactly. Feel free to help yourself to dinner.
Oh, thank you.
They do happy birthday wishes for like the person's birthday was the week before or whatever brings the next one.
I used to get that all the time. Yeah. In case you're curious, they are going to have the back. Sorry, I was correct. It wasn't like that. I don't know, but I did get 2 or 3 random phone calls last night. I didn't answer any of them. I thought about it. Oh yeah, and then she got no. Insurance pretty much like never ignore. Yeah. Welcome. I was literally like, dude, welcome. And she's like, it's gone now. What do you think it's so far? Yeah, yeah, I need to go back and look at this. Yeah, I know. She's like in a respiratory distress. Oh my god.
Hey, Fred.
Yeah, my teeth.
No worries.
Yes, no worries. EJ's words in our smoker picture. So now there's something else wrong. He's an email. Yeah. I wonder if Sharon is I think she does. She loves to just watch it.
No problem. You guys want to start the next one? Everyone's buddies next to you here. Everyone's here accounted for. So wound care, obviously, every day you're going to see whether you're inpatient, outpatient, from surgical wounds to decubitus to doctor, I have a rash. What is this? So wounds, just some basic terminology. Wound, you all know what that is. Acute wound is a wound that follows specific stages of healing. So it's, you start at point A, you go to the Z, it follows all the course as expected. The chronic wound is a wound that falls off the pathway somewhere. And we'll kind of talk about the pathway coming up here. So normal wound, that's affected by how severe the wound is, where the wound is, what type of tissue it comes across, scalp versus a knee versus an intestine or a blood vessel, and what kind of comorbidities that patient has, severe diabetes, CHF with peripheral edema, arterial disease. All these disease states affect wound healing. In order for the wound to heal, all the dead tissue has to be gone. It's probably got to have somewhere a good approximation. The wound edges should be relatively clean and healthy. and moisture plus or minus, but most of the time moisture is a good thing for the wound because it helps all the cells that are necessarily for healing to navigate to the wound itself and bring those important molecules for healing. It also reduces the pain when you're changing somebody's wound and packing that's in their wound. You're going to be taking in and out surgical packing. It reduces the pain if you just add a little bit of moisture to that system. And then blood, another one that's important is the angiogenesis, the blood flow to that wound. You really want that to be as beefed up as possible, so moisture will help to improve that process. So this is the pathway of wound healing. Depending on what you read, some people clump hemostasis with the number 1 with inflammation, but I think of it as totally different. So first you have to stop the bleeding before you can start healing. And bleeding can be severe or not. So this is just kind of the pathway. First you'll notice that the injury happens at point 0, and then it can go all the way to who knows when. Sometimes it can be a few months that it takes to heal some of these wounds, up to even a year after the entire process is done. But basically, you start with hemostasis. The blood clots happen. The platelets are coming. They stop the bleed. They put a fibrin clot on top of it. Fibrin with it carries all the factors that start inflammation. So then the wound, initially the wound to stop bleeding contracts, or not the wound, but the blood vessels contract. And then after the bleeding has stopped, then your body, with all these signals, vasodilate, and all the blood flow and all those factors can start to come to the wound to start healing it. So you get a little bit of redness. Redness isn't always a bad thing. It can just signify that that inflammation process has started to heal. Those cells that are migrating through the area are the killer cells that clean up all the bacteria and the infection. So the neutrophils, the macrophages, all those things that need to chew up the bad bacteria and get it looking clean and healthy again. Next, once your inflammatory process has gone, then you're going to start rebuilding healthy tissue. Granulation tissue is what the healthy tissue is called. It's the pink, beefy, well vascularized, good growing tissue. And that essentially is just a whole bunch of blood vessels mixed with collagen. Collagen's that nice elastic building block that helps the wounds to close over. Once that granulation tissue is laid down, it's just kind of put in there like a smorgasbord. Over the next period of time, then your body goes about remodeling it, making it purposeful, trying to get it as close to normal function as possible. So you're taking that Play-Doh and you're molding it into smooth lines, making the contractile forces along the normal pathway. So each of these processes is a point A that you can fall off and become a chronic wound, or B where we can intervene. So there's different intervention steps at each of these time points. A normal wound, usually about 6 weeks, the wound is about 80% back to normal. Again, it depends on how big it is. Up front, the first day or two, you might want that wound to heal a little bit, but in the long run, light activity is actually helpful, because just like the old saying, use it or lose it, when you have a wound and you're using it and bending it and moving it, those fibers that are coming to be remolded are going to line up in the correct direction. They're going to be along the tension lines and the tensile forces. So it helps to remold with activity. Again, chronic wounds, most of the time they're slowed. They either fall off at the inflammatory phase or the proliferative phase. Those are the two most common locations. And it's your job to figure out where it fell off and why. Can anybody think of reasons local to the wound itself why it might not heal correctly?
Oh, vascular disease.
Vascular disease, yeah, I'll think of that as more systemic, but like a systemic disease process. Like, we'll get there next, though. How about like the wound itself? It is filled with dirt or infection or stool or mucus, whatever it is. So infection, edema. If the person has poor, well, that's more of a systemic disease, is peripheral edema, but the wound itself has a lot of edema or too much swelling at the wound itself. Those blood vessels that bring all those good nutrients and things are going to be pinched off, and so the blood flow can't get to that tissue as well. Foreign bodies, if you leave a knife there, it's probably not going to be a good thing. You got to get the knife out somehow. Necrotic tissue harbors infection. You got to take a knife or something and get that tissue, necrotic debris, out of there. If you have a medical student who sews it up incorrectly and it looks horrible, and this, the opposition is, the surgical opposition is really bad, they should have called the PA student. You got to close your wounds correctly. And then tension lines, something on the thigh or anterior shin, or big muscular workout bodybuilders. If there's a lot of tension across the wounds, there's probably going to be, you got to think of a way to close it correctly so that it won't rip open. So in systemic factors, yes, now back to the peripheral vascular disease, the arterial disease, venous insufficiency, pooling in the legs. That peripheral edema will squeeze those blood vessels. If the blood vessels are calcified because of triglycerides or diabetes, then you're not going to get that blood flow to the wound. Somebody who's elderly, they don't have the collagen, that Play-Doh that we're remolding, they can't make it as much, and they don't have as many cells to build. They also have weak blood vessels, weak nerves, their skin elasticity is reduced, so elderly people have a harder time to heal their wounds. Diabetes, for obvious reasons. Malnutrition, you all should be experts by now. Smoking causes vasoconstriction. It causes a systemic inflammatory response to the body. So all those cells, your body's job to make these good healthy cells is reduced just from smoking itself. Immunocompromised, cancer patients, renal, hepatic disease, spinal cord injury, which we see commonly where I work. Those people can't turn themselves, so they're laying on their backsides, or their heels are pushing against the bed, their elbows. They break down skin all over their body because they just need to be turned every few hours by nursing staff. Other disease states, collagen vascular disease, somebody with lupus or one of those disease processes that, again, it's all about the collagen and that Play-Doh to remold. So you walk into a room, and how are you going to evaluate a wound? You're going to do a good history and physical before you come back and talk to the preceptors. And what do you want to know? How did the wound happen? What caused the wound? Where is it located? What size is it? Is it draining anything? Blood, stool, mucus, pus? What treatments has that patient tried already? Have they tried packing their wound, or a wound vac, or other agents you can put in there, and it's failed? What kind of medical problems do they have? Diabetes, smoking, kidney disease, all these things that affect wound healing. Alcohol use. Also part of the social history that's maybe not as thought of as much is when people leave the hospital or leave your clinic, they're on their own. So what factors at home do they have? What resources do they have that will help them get this wound healed? Are their family? Do they have family? Do they have friends? Is somebody willing to put dressing into their butt wound 5 times a day? Not everyone has a good friend like that. So physical exam, diagram. Most everyone uses electronic records by now. So every electronic record, I'm sure we have scribes in here somewhere, you have a diagram built for you. You just click a button, and left shoulder has a wound this big. What do you want to know? Cellulitis, redness, odor, drainage, color. And then I use photography a lot. Actually, now our electronic records even have a function that will upload a picture directly to a patient's chart. Just because it's a communication tool, I can sit and document and describe something in words, but it will take 1 second to look at a wound and say, that's bad. And then just general signs on their body. You see signs of vascular disease, whether they have a big old beard that is full of soot from their smoking, or their teeth rotted. Do they have vascular disease? Are they missing a leg from their diabetes? Things that you kind of walk into a room and you can assess. You won't even know you're thinking it, but you're going to be built to understand kind of the complexity of diseases just by looking at somebody and getting a global overview assessment. So who wants to take a shot at describing this? Well, I'll give you a little history. Guy fell from a ladder, may have been drinking a little bit. I don't know why they always drink before climbing. He, about 2 weeks ago, had a plate put in there because he broke his ankle. Nothing like that. Yeah, if you walk into the room and your attending says, hey, this person needs to be discharged, go discharge them. What are you going to say? Hey, I can't discharge this person because... And you take them a picture and you text it to them and say, this is why. So, yeah, it looks infected, but that's, how are you going to prove that in a chart? The orthopod that did the surgery, that's not infected. He can go home. He's fine. Protuberant, okay, it's swollen. Yeah, it's swollen around the incision site. There's probably a little bit of edema fluid there. It's red. Anybody? Red. Flaky. Yeah, that flaky signifies that, called epidermolysis. The tissue at that area was so swollen at one point that the epidermis actually died and is now flaking off. The swelling has reduced, but because the edema got so big, it outstretched the blood supply to the epidermis and it's flaked off. So what other, don't look at the wound, look at his leg. What on his leg might concern you? It's a male. I mean, he should be there's no hair at all. He has thin skin, it's shiny, there's not an ounce of hair. I mean, a 50-year-old male should have some hair on his body somewhere. So he probably has bad arterial disease. How about this one? So her history. Huh?
Oh, we did an abscess, looks like a little.
I'm going to trip on this cord.
You can undo it.
No, I'm just going to lengthen it a little bit. The chicken wound?
We did abscess incision, that's what quick.
Okay.
What would you?
So this is, I think she's in her 55, diabetic. She, a few months ago, had a ostomy creation for perforated diverticulitis. And she came back now for elective surgery to take down her ostomy and put it back, the tubing systems back together. So you walk into a room, she's supposed to have day 3 or 4. What things are you going to want to know about her before walking into the room? Vital signs. So fevers, blood pressure, heart rate. Nutritional status. You're just sucking up now. Nutritional status, yes, that's important. What else? What can you see in the computer? You don't have to see her yet. Diabetes, so you're going to see what her glucose has been. BMI looks large. How about laboratory data? electrolytes, white blood cell count is huge, renal function is huge, yes. So you can tell, is she acidotic, does she have a huge white count, is she anemic, what's her fever, what's her BMI, what's her diabetes like. So all those, and then you walk in the room, you pull up her sheet, and you're like, ah, ah, what do I? So there's pus, there's redness. It looks like somebody was already concerned about it because the line that somebody drew here is already fading. So somebody was already concerned probably yesterday that they drew a little marking around it. It probably looks like yesterday also they already opened part of the wound down here because there's pus draining here. Usually pus will go where gravity takes it, so usually it comes out the bottom of the wound. But now it's coming out the belly button. So what's your next step? Culture is huge, yes. That's also another thing to know about before walking into the room is she have a history of VRE or MRSA or whatever it is. You're in the hospital by yourself and you have a slew of nursing staff that is begging for you to do something. What are you going to do? Yes. Yes, exactly. So you get the staple removal and you start popping staples. And you take cultures and you irrigate the heck out of it. Specifically for this one, we're going to kind of follow her a little bit throughout the rest of the lecture, but another important thing to know for abdominal wounds is the muscle closed still, or has she completely eviscerated her abdominal wall? Because if her insides are now her outsides, she's going back to the OR. So this is the physical exam. I think we kind of touched on this. Labs, we kind of touched on this. So, electrolytes, CBC for the white count, glucose. We talked about A1C to C. Her glucose today might be 300 just because of that infection. That's a stress response. But is it 300 just today, or has it been 300 for the last 3 months? Albumin, pre-albumin because of the nutritional deficiencies, and then microbiology. So good, I think you guys got all of them. Imaging, for that specific wound, the abdominal wound, I might not image until I've popped it open and seen what's underneath of it. The most important thing is controlling the source. But just in general, when you're assessing wounds, whether in the ER or primary care, the options for imaging, usually you can start with ultrasound, pretty inexpensive, pretty accessible. And somebody with an arm abscess or something, you can see if it's a fluid, complex fluid collection, if there's fluid at all under there, or if it's just raging cellulitis. Kind of the next step for something more that you're really worried about, it would be CT scan. And this is an area where, especially the buttock region, diabetic, obese diabetic in the ER will land something and then send them home after they've packed this much stripping into them, given them Keflex or something, and 2 days later they'll come back and they'll have corneate gangrene. So they probably already had a nasty infection that you only caught the tip of the iceberg with your little lancing tool. So in that specific population, you probably are going to be thinking, dirty area, immunocompromised, maybe their white count's not just 12 or 13, maybe it's 14, 15, 16. That person probably needs an actual CT scan. And then lastly, the guy with the ankle with hardware in there, you want to know if that hardware is infected or the bone that it's securing together is infected. The only way you're going to see that's with MRI. So vascular assessment, again, you can do this at the bedside for anybody. You can look for signs of arterial disease. I think we kind of talked about the hair a little bit, the shiny skin. All you have to do is put your hand on their pulse. You can feel if it's a bounding pulse in their femoral region, but by the time you get to their popliteal, it's non-existent. If if their nails are deformed and ugly looking. Some non-invasive things you can do, you can send them for a duplex ultrasound. They can kind of assess the flow of vascular flow to whatever organ you're trying to perfuse. And then who can think of another bedside tool that you can do in the office? You know, say you're in a vascular office and you're having to decide whether you're going to do a BKA or an AKA. What might you want to document in the chart?
You look at the Doppler to see the blood flow.
Doppler, but even easier, less expensive.
CBS,
Yes. What is that?
the ankle and radial index and the flowing angle versus the brachial index.
So how do you do it?
Great question.
Anybody know how to do it? ABI, has everyone heard of it? Ankle brachial index. You strap a blood pressure on their arm, you strap a blood pressure on their leg, and you compare the two. And if it's less than 0.9, the systolic of both. If it's less than 0.9, it's a poorly vascularized area. We'll do it actually a lot in penetrating trauma. If you have a palpable pulse, but it's not quite as, say somebody got shot at the knee, you're trying to decide whether or not to explore the wound or send them for a CT scan, a CTA of the leg. If you take a blood pressure below the cuff, below the injury, and it matches their arm, then there's no vascular injury. These are just surgical wounds you might hear if you're in the operating room. They're always concerned whether it's a clean case, a clean contaminated or dirty. It usually dictates how you're going to close that wound and what kind of course you expect for that patient post-operatively. So usually for clean or clean contaminated, you'll take a suture at the end of the case or some staples and you'll close it. For a dirty case or contaminated case, you'll probably leave it at least partially open. So clean, here's some just kind of notes about what it is. It's not an emergency, elective surgery. There's no break in technique. Easy thyroids, your breasts, all those surgeries, cosmetic surgery. They're going to end up getting nice little cosmetic closure at the end. Clean contaminated is when there's maybe it's starting to be a little bit of an emergent or urgent case, but there could be a controlled opening of usually a sterile environment, the urinary bladder, maybe a gallbladder has a very small spill, Whipple's. So this is a minor contamination. Again, you probably close that wound at the end of the case. Contaminated is when you have a gross infection already of spillage from the GI tract, from a nasty gangrenous gallbladder, a perforated appendix. These are penetrating trauma that's less than 4 hours old. These are starting to get to be dirty wounds. You're probably a little cautious about doing a nice little subcuticular closure at the end of the case because you're going to turn out to be a lady with an infected belly. And then dirty is that usually they have an infection before you even start, a nasty infection before you start, like perf colons, INDs. At the end of this, you're going to maybe close the muscle or fascia, but you're going to leave their skin edges open and pack it. These are just different ways to manage wounds, to clear up. These are just the more definitions. I guess the bullet point here is just if you prepare well for a wound to take care of it, it should heal well. Set up and getting your stand correctly put together helps in the long term. Irrigation is the very most important thing you can do. Surgeons always say the same things over and over and over because that's the way they're trained. They'll always tell you dilution is the solution to pollution. They'll say it, they'll be like, come on back, I've heard that like 100 times. But it's true. It removes the loose material. It removes bacteria. You're getting all that nastiness out of there. Other ways you can debride, the most commonly is surgical. You take a scissors or a knife or a curette or something sharp and you're scraping that infected tissue out of there. Enzymes, a lot of times this is more the wound care nurse or the wound care clinic, the diabetic foot ulcers, those things. There's a whole line of commercial products that you can strap on there either by ointment or patch or a pad or impregnated into a packing, and they have enzymes that chew up that bacteria or the infection. And then lastly, I think 2 times I've seen done is using medical larvae to come and eat those bacteria. So this is a diabetic wound on the lower leg. It has kind of this yellowish exudate. It's definitely a chronic wound that's been there for a while. It has irregular edges. If you try to just take a knife or a curette and scrape at that, now you're giving somebody who can't heal a wound, or a bigger wound, to heal. So instead you can buy these freshly farmed California sterile larvae, strap them on there and let them, make sure the nursing staff doesn't scream at you too much, and cover them up, and a few days later you have more of a, they just eat the dead tissue. They don't eat the fresh tissue. They'll turn that chronic wound, now they've created fresh wound edges. They've restored that normal pathway for them to start healing through the proliferative phase again. So how are we going to close wounds? Anyone have questions yet? Yes?
What happens to the larvae?
They become flies and they fly away. No, you just put them in the time in a red bag.
You step on it and make the crunching going.
Find a chicken and tie it up in a bag and yeah, that little enclosure thing.
I was just worried if they swim through the wound.
No, I mean you're not going to be putting it on like an open belly wound.
Is that something the patient has to order, or it's not a regular treatment yet?
No, that's not me. I mean
So we probably want to have.
that's more specialized. That'll be inpatient, super specialized. I mean, it takes many days for them to come from California.
And there's a side note, I work in urgent care in a really low income area. We had a gentleman that was brought in by his friend because they both homeless, of the constant itchiness.
Head maggots on them?
Yeah, they were not medical maggots. However, the wound edges and wound itself were absolutely clean.
Yeah. Should have tried to save them for later.
It was impressive.
Yeah.
It was impressive. It was at least 100 of them that we removed, and we don't know what's the big
Well, that's going to stick with me, thanks. All right, so there's 3 types of closure. Primary, you're doing at the time of injury, or it's at the time of surgery. You're taking a suture, a staple, and you're closing it with the edges approximated together. Secondary intention, you're going to let that wound heal by itself on its own. Usually you're packing it or using a wound vac. And the wound is going to heal from the bottom all the way up. It's going to fill in with granulation tissue. It's going to contract and remodel. And eventually it'll be relatively, it's not going to be the prettiest scar, but it's going to be healed. And then last is tertiary, more commonly we call it delayed primary closure. Usually these are for the contaminated wounds at the time of surgery, something you're worried about getting infected. You pack it for 3, 4, 5 days. You let you make sure all that infectious necrotic debris is washed out. Hopefully you get maybe even a little bit of granulation tissue in there, and then you take sutures and you close it. So this is a picture of. So I think we're going back to Our Lady now. So you can see this is her old ostomy site here on the side. That one looks perfect. That's usually the one that you expect to get infected because this is where the stool bag used to be. But her midline got infected. So now we've opened it up. You can see how big she is in this picture. You know, there's a lot of space in there to deal with. Fortunately, her fascia, her muscle, is not necrotic. It's together. The stitch is still holding her abdominal cavity closed. So you intervene fast enough. So this area of tissue we call dead space. I think the dead zone, I guess. It's the area that you have to figure out how to get closed safely without trapping infection under it. If you just take stitches in this setting right now and close at the top, A, it's going to be under huge tension because you can see how much the gap is there. And B, you're probably going to trap some fluid. It's still creating that inflammatory fluid. You're probably going to trap some of that fluid under there, and you might be recreating an infected cavity. So the ways that you can manage it are by packing. This is the traditional way that they've been doing for since surgery was invented. More commonly now we're using wound vacs. And I'll describe what that is. So this is just the process for what yes?
Do you ever use hyperbarics?
We don't have a chamber at our hospital. More of the tertiary care centers do, so they'll use them a lot in like burn care and so no, it's a good beneficial thing, but we just don't have access to it. It's very expensive. So what the dry dressings or moist to dry dressings, essentially you're just soaking a strip of gauze, a long strip of gauze, you're packing it into the wound, you're covering, once it's packed all the way on the fresh pink tissue, all the dead space is filled with this gauze. Then you put a dry dressing on the top and then tape it down, and you expect that fluid that's being produced by the body is just going to, and potentially infection, is going to be continued to evacuate so that dry gauze can get changed a few times. But usually you're doing that twice a day, and anybody can do it, a nurse, the patient's family, the patient themselves if it's accessible location. It doesn't take any special training really. A wound vac, however, is this kind of controlled vacuum sponge. The sponge itself is hydrophobic, so water goes straight through it. It doesn't soak into the sponge itself. And then you cover, once the sponge is on the inside of the wound itself, the entire dead space is filled with the sponge. You put an occlusive dressing on top and then connect it to a suction canister. And how this helps is it reduces the edema, it promotes blood vessel growth, angiogenesis, stimulates the circulation, and it can help reduce some of the bacterial burden. And then lastly, like I was talking about with tension forces and movement and how wounds heal along the tension lines, if you're applying more tension to the abdominal wound toward the middle of the abdominal wall or midline of the body, that's how the wound is going to want to heal. Versus laterally, where that open wound is probably pulling, the forces are going laterally, the wound vac will pull it more immediately. So essentially, the sponges come in this little rolled up, pre-formed thing, and you can either unroll them or leave them as is, and you fit that black sponge in the entire pink tissue cavity, and then you strap on that occlusive dressing and apply a gauze pad or a suction pad and connect it to a canister. Now you've changed a wound that is kind of difficult to manage. It takes a lot of nursing care, twice a day, every day for months, and you've changed it to something that needs to be changed 3 times a week. However, it does have to be by somebody with training and expertise, and it's expensive. So if you're uninsured patient population, unless you can get a charity supplier for them, it's very difficult to get. So this is what the suction battery box looks like. The one that patients can go home with this. Usually it's more of like a fanny pack, smaller pump situation. But in the hospital, you expect it's going to be more fluid, more drainage, so they have bigger pumps, more suction canisters. By the time they're ready to go home, it's a smaller pump, smaller output. And then you might convert that wound, instead of taking potentially 2 months to heal, probably take it down to 3-4 weeks of wound vac therapy before her specific wound is healed. There are exceptions of when you should not use a wound vac, however, even though it's very beneficial. Especially the most important one is any exposed vital thing, like a blood vessel or intestine. You put a sponge, a suction pad on top of a vessel, and you erode through that vessel, you're going to be bleeding into the wound vac. Probably 3-4 years ago, one of the JMU students was precepting with, we responded to a code blue, and another surgical team had a Fournier's gangrene. They put a wound vac on top of the femoral vessel, and she bled to death from the femoral artery. So, and then same thing for intestine. If you put a sponge, if that lady's fascia had separated and we didn't recognize it, and we put a black sponge on top of that and started suctioning, a day or 2 later she's going to start having stool inside the vacuum instead of the inflammatory fluid. Other situations, if there's a malignancy, you don't want that malignancy to have better blood flow and better healing, and you want that secluded. Fragile skin, especially older people, or the front of the leg, that plastic it has to be occlusive, so every time you take that plastic off, you could be ripping fresh skin with it, or if they have an allergy to adhesives for the same reason. So these are just some bullet points that the program wanted to make sure we talked about somewhere in the lecture. The local anesthesia, you'll use a lot of that, especially in the ER. They always, you always get pimped on how much is a safe amount. What are the side effects of lidocaine toxicity? Usually you start with some numbness or tingling around the mouth and tongue, and then you can progress to cardiac arrest. There's some other symptoms, but the most significant one is cardiac arrest. So here are, it's a weight-based system. You can give, why can you give more if you have 1% lidocaine with epinephrine? Why are you allowed to give more of that compared to plain lidocaine? It does decrease toxicity, but why? It makes it work much better, actually.
You can shrink the blood vessels.
Yes.
Systemic absorption.
Exactly, and it keeps it takes everything you're injecting, it keeps at the site of injection because of this vasoconstriction. There are places you shouldn't use epinephrine, lips, tips, fingertips, nasal tip, earlobes, genitalia. You don't want those things to become ischemic. So just, and there's a whole bunch of different formulations of lidocaine. The most common is 1% lidocaine, but in the OR you'll have 0.5% marcaine or 0.25% bupivacaine, or any of those potential formulations. So 1% just means 10 milligrams per 1 ml. Excuse me. And fortunately, it does say it on the bottle. Here's a little chart you can look up at some point in time. So when you're trying to dose, you're just kind of quickly guesstimating their body weight, or you kind of know their measured body weight. If you're using 1%, we'll just say we have a 70 kilogram person. That patient, our conversion, our factor is 4 milligrams per kilogram times 70 kilograms is 280 milligrams. That person can have 280 milligrams divided by the 10, so he can have 28 mLs maximum infusion. Most bottles come 20, 25, I believe. This one happens to be 50, so if you run through the whole bottle of that, it's a problem. Then with lidocaine, with epi, you can give more because it's going to stay more local. So now we're up to 7 milligrams per kilogram. Potentially a pediatric patient 10 kilograms. You can give that pediatric patient 70 milligrams of the medication or 7 mLs of injection. Next is just tetanus prophylaxis. Clostridium tetani. Usually it's involuntary muscle contraction. These are the wounds that are prone to getting them, very contaminated wounds, dirty wounds, old wounds, deep wounds, dog bite, animal bite. Tissues that are devitalized with vascular supply are high propensity. Stellate is like a window shattering with spider webs out to the outside. So if somebody hits their head with a baseball bat, it's probably not going to be a linear laceration. It's going to be a spider web of explosion. So just basic, you can again look at this on your own. The most basic is if they don't know, it's safe to give it. If somebody comes in comatose and from a car accident, you can give them tetanus and you're not really going to cause that person any harm. The only time you don't have to give it is if you know for certain they've received it within the last 5 years. Everything in between that is plus or minus based on all of the factors I just talked about, whether it's a dirty wound, contaminated wound. If it's been less than 10 years and it's a nasty wound, you're going to give them a tetanus vaccination. The last thing is leg ulcers. There's a few different types of ulcers that the boards love to ask about. Arterial ulcers or arterial system ulcers. Usually they're going to be on that leg that doesn't have any, it's a shiny leg, there's no hair at all. They're going to be very distal because the blood flow is the weakest at the distal aspects. And they're round and punched out. That's one of the classic description. Venous, the leg surrounding looks like that chronic venous deficiency. The skin is hyperpigmented. They're usually on the medial aspect, the inner ankle. And they're going to be small, irregular shaped, ugly looking wounds. Diabetic, most of the time they can't feel the bottom of their feet. They've been walking around with something in their shoe but they didn't know about it. So usually they're going to be on the plantar surfaces of the feet. And then their feet also have very thick calluses. So if somebody were to take a guess at, start with C. Okay, arterial. A. Good. Huh? I heard arterial and venous. Medial aspect, hyperpigmented skin, irregular shape, shallow based, to venous. And then hypertrophic or calloused, bottom of the foot, ugly looking wound is going to be diabetic. Good. This is just basic summary. I don't think I need to reiterate too much of this. Any questions about what we talked about? I'll just quickly go into the case studies and you guys can talk more than me now. So patient 1 is a 55-year-old female. She has a 1-week history of right thigh pain. Part of her history that you're taking is that she's a nursing home resident with insulin-dependent diabetes mellitus, and she had a right BKA, which is a below-knee amputation, and she's had a progressive pain, progressive redness of the right thigh, and she also says she's been having fevers, and her husband's like, yeah, she's just acting a little kooky. She's not been herself over the last few days. So what are the things you're already making checklists in your mind? What things are you thinking she could put the diagnoses? What? Yep, she's definitely going to have cellulitis. Encephalopathy related to, sorry? Bacteremia or sepsis. So those are, you already have 4 diagnoses of things that you know, so what kind of tests are you going to be ordering now? Are you going to do the ER thing where you just hit a button and get all the labs, lipase, you know, probably going to get a pregnancy test and probably ultrasound of the gallbladder at some point in time. Sorry, I know I can be a little jaded, I'm sorry. Probably should turn that down. So what labs? Okay, good. CBC with diff. What do you see on her diff? I was asking him.
Yeah, like a white count and
What cells? Neutrophils, left shift. Okay, blood counts. What about anything else we might? All right, so let's go see her now. So this is her leg. So this is the well-healed stump of her BK. So before we even get there, what are her risk factors for healing or infection? What? Diabetes. Sorry?
Immobility.
Immobility. I didn't hear you. Yeah, it could have been 20 years ago. We don't know. Insulin injections, sure. Probably could be a site of one of her injections for sure. Anything else that might? Nursing home is huge. Yeah, the propensity for diseases that come out of nursing home just from sheer quantity of elderly, advanced disease, bedridden, MRSA, VRE, C. diff are huge for that type of population. And then also BKA, maybe it was due to her diabetes, but maybe it was because she has horrible vascular disease. She probably does because of the diabetes. So we're not really sure why she got her leg cut off, but we could ask her. So who's going to describe this? Don't all jump out at once. Ulcerated, okay. So she has a black eschar. She has purulence, some, yep. She has that epidermolysis thing we talked about again, where it was probably very swollen before it started becoming a flesh-eating kind of thing. It's very red. What are you gonna, if you touch it, it's gonna feel hot. So let's say you're the surgical PA on call, what are you gonna do? Wound culture, sure. You might wait a little while longer so you can get it. If you just swab somebody's skin, it's going to pop up positive. So, especially a nursing home patient, you might wait a little while longer. But oh, for sure, yes. So, first thing in the ER, this looks pretty horrendous. The fact that it's spread toward her midline. There could be some lymphangitic spread. There could be some bacteremia. She could be in shock easily. So you want to make sure she has good IV access. You're going to make sure she's getting fluids. You're going to give her IV antibiotics immediately. That's the only thing that helps severe sepsis besides source control is initiation of IV antibiotics as soon as possible, and you're going to call the operating room. When you go to the operating room, are you just going to like make a little stab hole and call it a day? What kind of surgery are you going to do? I heard the word. Huh? Oh, I thought you said excisional debridement. I was like, wow, go excisional debridement. So you're going to go and you're going to create a big wound and cut out all the dead tissue and all the infection. This is probably where you'll kind of get your cultures because it's a deeper space. And all this is beautiful. You have nice healthy tissue. There's not that little blackness up at the top there is probably a little bit of bleeding that was controlled with electric cautery, so that's not necrotic skin. And then what are you going to do after you leave the operating room? You're just going to put a little patch on top and send it to the floor? Wound vac, yeah. I might wait a day or two, but I think a wound vac in this scenario. So for wound vacs, usually you want them to be a nice healthy wound. If you put it on while the wound is still infected, and you put a occlusive barrier on top of pus or something, that's going to continue to flourish. So usually you have to make sure it's a nice clean wound. But I agree with you. I think the wound was pretty well demarcated on presentation. She did have some of that erythema going northward, but that's just cellulitis. That wasn't indurated. It wasn't abscess collection. You've probably gotten a CT of this also. You're not just going based on your physical exam here. You want to see if this spreads up the fascial lines and the fat comes up to the hip, or so you've definitely CT'd this. So yeah, I agree. A wound vac you could put here, or just traditional packing. So they did just that. They put a wound vac on, and long term, she already has all the risk factors for healing that we talked about. We don't know that she's going to be able to heal this wound. Even with the wound vac in place, it could take many weeks. So what could we try to do for her once we know it's a clean wound? Delay primary close. So you start to regenerate some of that healthy tissue. You get starting to get some granulation tissue. There's no more infection at all, period. You want to try to make it a more manageable, smaller wound. So you close the skin primarily, and you're managing the dead space with a JP or either a Jackson Pratt drain or a Blake drain, because that fluid is still being, the inflammatory fluid is still being generated. You have to suck it out so that you don't create a seroma or an abscess cavity later. And then you just pull out the drain probably 3 to 5 days later, and then take out the sutures probably 10 to 14 days later. So let's see, our next patient, the next room over, is going to be a 20-year-old who liked to drink a little bit and was showing off for his girlfriend, and put his dirt bike and he hit the clutch, and the front tire goes up and falls back, and the kickstand goes through his leg. So after he stood at home, after he got some more whiskey and tried to get a wrench and take it out himself, he finally decided it was time to come to the ER probably 3 or 4 hours later. So when you come and see him, what kind of physical exam are you going to do? Not a mini mental status exam.
You want to make sure he's like neurovascularly intact, so you could do the neurotracheal index.
Yes, very good. So palpate the pulses. Can you move his toes? Can you feel? Can all those good physical exam findings. What kind of imaging are you going to do? Let's say he has good pulses. He's moving his toes. Any imaging you might get? Yeah, you could go for a CT, but he was at home. I think he even tried to walk a little bit. probably can just get by with plain X-ray, and then based on the plain X-ray decide if he needs imaging. But if you have good palpable pulses, his ABIs are normal, his neurovascular status is normal, you could probably get by with just your exam and a plain film X-ray. So this is the kickstand. The EMS was able to get it disconnected from the bike, and it looks like it goes through the medial aspect of his left leg. And then this is his X-ray, plain film X-ray. So I wish I had so what other, besides this one X-ray that we have here, what other X-ray do you need? Lateral view, because we have no idea. Just based on this, it looks like it goes through his bone. The bone isn't fractured, so it either goes in front of the bone or behind the bone. Probably not in front because the anterior compartment is very small. So his goes through the calf muscle on the left leg. What are you going to do? Cut the bar off, send him home? So you have to get it out. You have to take him to the operating room. So you're going to get your surgeon on board. So he goes to the operating room, and you open the medial leg, and his muscles just jump out at you. They spring. The skin, you cut that skin, and his muscles are engorged. What process is that? Compartment syndrome. So what are the symptoms of compartment syndrome? The P's. Pulse. All right, we'll go down the line. Pulse, you said. Pallor. What kind of pain? Pain out of proportion. Nurse calls you, I've given him morphine once, didn't help. Give him another dose. 2 hours later. He says it's severe, 10 out of 10. Give him more. I'm sleeping. Give him more. He's crying. 20-year-old's crying. It's pain. You cannot even touch his leg because he's in so much pain. So pulseless, pallor, pain out of proportion. Huh? How does it feel? No. What temperature is it? A leg without perfusion? Cold. So cold, which is called poikiliothermia. And there's one more. Nerves, paresthesia. So, what's the last one of those to disappear? If you go and see the patient and you think you're doing okay, but it's the last one that goes away.
The last one to go, do you mean
Out of the list of 6?
Yeah.
If you get to 6, you're way behind the 8 ball. So what is 6 that's the last one to go away? Or to show up, whatever the correct way to say it is. Pulse. Arterial system is hard to compress. So if you've been giving him morphine all night and hasn't touched his pain, you haven't seen him though. He can't move his leg. He can't feel you touch him. It's cold to touch, but he still has a pulse. The nurse says, "Oh, he has a pulse. It's okay." So that's, if you get the pulselessness, there's already dead muscle in there, no question. So back to our patient. In the OR, his muscle bulges at you. So far, you've only opened the wound this much. What's going to make you do a formal fasciotomy? What intraoperative or bedside procedure? How are you going to test the compartments? How do you test the pressure? Yeah, it's cool. The over-the-counter, off-the-shelf one is usually called a striker. But all you have to do is take an arterial line, just like they do in the ICU. It's just a pressure transducing, and you put it into the muscle compartment, and you can measure how much pressure is in that compartment. So this is called a fasciotomy. You go down on both sides of the leg. His pressures were in the 60s, so you cut the fascia all the way down from ankle to knee and open the skin as much as you need to. Just because he had compartment syndrome, we had to open up the lateral compartment too. And then this is before leaving the operating room. We just put these elastic vessel loops in there so that the skin would kind of retain its the elasticity, and kind of when we were ready to close them, it would be more of a closable wound, but it allows for swelling because they stretch. So then a few weeks, probably after a day or two, you're going to be able to take sutures and close that wound. On this wound, you're probably going to put a wound vac for maybe a week to 2 weeks, and if that skin is still not able to close, you're going to put a skin graft on top of it. So he ended up putting a skin graft on the medial aspect of his wound. So the last one, this is a 35-year-old guy, African-American male. His chief complaint when getting admitted to the hospital was this chest wall rash. Of clinical significance, he signed out AMA from one of the hospitals up north about a week ago because he had this group A strep bacteria infection in his bloodstream, and they ran all these diagnostic tests and couldn't find anything, and he just got fed up after about a week of all these negative tests, and he said F it and left. Can we take that off the recording? Somehow he got admitted to the floor where we consulted, and that's his rash. Again, you have that epidermolysis. That skin had been so swollen that it killed the epidermis. He has necrotic tissue on the right-hand side of his pectoral muscle, up around his trachea site. He has a kind of infection draining out from his neck. So he's in the operating room now. What kind of surgery are you going to do? Just lance him, pack him, send him home? Extensive excisional debridement with a knife. So he's now turned to the side. His head's up under here, the body's down here. This is the skin of his chest wall that just is peeling. The fat pad above his pectoral muscle is just melted away, and the entire skin has died. So all this is just dead fat tissue that needs to be cut away. So you keep debriding until you get clean, healthy tissue. So it's the most important part of necrotizing fasciitis is aggressive debridement at post-op on day 1 of surgery. So you have to go until there's fresh, clean tissue all the way. Here, probably 95% of the dead tissue is gone, and now you're starting to get toward vital structures, subclavians and tracheocytes. You just kind of have to call it quits at some point. So even though he might still have a little bit of infection left, you're probably going to put a wound vac on this at day 1 of surgery to try to manage it. So this is what his first wound vac looks like. Long term, what are the risks of a wound like this healing? If you have a severe burn, another example, this is just a very bad burn. So if you have a burn across somebody's chest, what are the long-term problems of that burn site?
That scars, would you have trouble with chest expansion?
Yes. Yeah, you got restrictive chest expansion. So that contracture, the skin heals and forms a scar that doesn't have the elasticity that a normal skin does with collagen. So it was a week after he's already gone back to the OR probably 3 times, had vacuum changes, you're treating his bloodstream infection, you're probably gotten an echo to make sure he doesn't have any vegetations on his heart. He's been in the ICU this whole week. And long term, you do the same thing with the same skin graft will form just like a burn scar does. It's not the elastic stretching capacity of a normal scar tissue, of a normal skin tissue. So there's products that you can put on that act as like a basement membrane. There's a variety of them, but you can suture it in place. That's this little stretchy, bendable material that acts as a basement membrane. It's used a lot for diabetic foot ulcers as well. And it helps to provide that environment for material to grow into and provide the elasticity. So that's all his elasticity and strength. And then you put a wound vac on top of that, you wait another week. Now his own tissue has grown through the mesh, and that pink healthy tissue is what we love to see. It looks like the graft took. And then you skin graft on top of that because you already have a basement membrane that's flexible and movable, and so it's his skin graft on top. You mesh it so that there's fluid. Obviously you're going to get fluid through this. The fluid can be evacuated. You're not going to have any fluid underneath the graft that doesn't allow for incorporation into the body. And 4 days after skin graft, you've probably taken most of it. And then these are just what the skin graft sites look like when you take a donor graft. You take it from their leg. So now you not only have this wound to deal with, but you have this wound. So, these people are in the hospital. He was in the hospital probably 5 or 6 weeks at least. His nutrition is huge. He's somebody who might be supplementing. If he can't swallow, he's definitely somebody who you're going to put a feeding tube in and supplement his nutrition. Yes?
How long did that debridement take?
I think 2 to 3 hours or so, because you start minimal and you keep getting maximal and maximal and maximal, and you keep going. Once it starts bleeding and you see healthy tissue, it's a good sign. So each of the borders you go, not only width-wise but depth-wise too.
You probably mentioned a problem with it. Was it hepatitis fasciitis? The diagnosis?
Yeah, he ended up having, he had gotten a call about a month before from an HIV clinic to tell him about his positive result, but he didn't want the result, so he didn't call him back. So we found out while he was hospitalized that his viral counts were off the chart. So he had immunocompromised state, and then somehow got a severe bloodstream infection that probably started somewhere here and just continued to flourish until, even on our CT scans that we did pre-op, there was never, because there's not much fat here, especially in him, there's not much fat, so there wasn't much fluid that you could see by radiology. So even our CT scans didn't look as bad as this. So the other hospital, I'm saying, I don't think was at fault for not finding it. It was just, he was at home for a week brewing and then came in.
How much during the debridement and then all the skin grafting are you doing as a PA?
Sorry? PA?
As a PA versus...
It depends really on who you're working with and what your comfort level is. For that person in particular, the first surgeon was one of our locums doctor who comes PRN, and we have a good relationship. So I was in the first debridement with him, and you can kind of see what's dead and what's not dead. So you're trying to get somebody who's on death's doorstep in and out of the operating room as fast as possible. So not much of the skin there. If you make a cut that's a mistake, there's not many mistakes you can make with that. So it's pretty, you'll kind of see what's obviously dead and what's not dead. So you got to, in a case like that, I could do a lot. In the follow-up cases, the surgeon who ended up kind of honchoing the rest of his care. That one of the full-time surgeons who's like specializing in skin stuff. He and I also have a good working relationship and talk about wound care a lot. So all the skin grafting surgeries, the dermal grafting surgeries, he's doing part of it, and I'm doing part of it on opposite sides. So it's just a lot of suturing. For the first week or so, yeah, we had him in ICU because something like that, they're in shock. I mean, he's bacteremic, sepsis, so he's not only on the ventilator for pain control, but he's on the ventilator just because of severe illness.
At what point, like, where are the deciding factors to bring him up?
For him, once his sepsis and somebody who's acidotic and sepsis breathes really fast. So you get their fluid status under control. It's a big burn wound, so they're going to be super sursy and require a lot of volume resuscitation. So he probably needs at least 3 to 4 days of just medical treatment for his sepsis and shock. And then once you have source control and the antibiotics circulate and the sepsis kind of sepsis acidosis correct itself, then you get him off the ventilator. And the wound, the first day or two, you probably take him back every 12 to 24 hours and you're making incision, or if it's neck fascia spreads along the fascial lines, so you're going and cutting until it's not spreading anymore. That's why being aggressive at the first point of contact is so important, to try to get it under control. So once your source is controlled, your sepsis is treated, the wound is starting to look clean, you're probably going back to the operating room every 3 days for just a dressing change, and then grafting and things. So probably a week of intubation, and then every few days for the surgery. Any other questions?
When you said that vacuum is expensive, what expense are we talking about?
That's a very good question. I actually don't know off the top of my head, because once we get to that point of making a decision for discharge with a vacuum, usually a social worker or caseworker is involved, and working with insurance. It's all based on the insurance company's reimbursement, or how much they pay and what their rates are. And so off the top of my head, it probably varies from institution to institution and insurance. Questions? So does anybody want to come and play with our practice for a little while? So I think Christy is going to start doing some general surgery rotation. Right now, historically we've only been an elective rotation, like either critical care or trauma, emergency surgery. But I think starting for your class, she's going to start considering for general surgery rotation. So if you guys want to be in Fredericksburg and do general surgery, we'd be more than happy to have you.
Is Mary Washington a level 1 trauma?
2. Yeah, because we don't have a research. There's no medical school involved, so it's us and the surgeon. There's no residents. There's no medical students. It's PAs and NPs and surgeons, and that's it. So we don't have a research grants and things like that. But I think Mary Washington, it's either the second or the third busiest ER in the state. So we have definitely a lot of work to go around. All right. I think you've heard me talk enough.
He said it because she extended there you go, it worked.